Okay, everybody, we will get started. Thank you so much for joining us tonight for this SNP webinar. My name is Amanda Giratano, and I'm very happy to have Adam here with me to talk about BMT and hematology oncology and all things physical therapy. Just a little background on myself. I actually just moved to Dallas, Texas. I'm working at UT Southwestern in their outpatient cancer care building, which I'm really excited about. I also am on the mentorship committee for APT Oncology, and I'm the co-director of professional growth and educational resources. Adam, why don't you introduce yourself?
My name is Adam Matichak. I'm a board certified oncology clinical specialist. I do inpatient hematology, oncology, bone marrow transplant, and immunotherapy at Stanford Hospital in Palo Alto, California, where I've been for the past 9 years now.
Awesome. We're really happy to have you. Thank you so much for joining us.
Yeah,
Why don't we just start with a brief overview of what you do and about bone marrow transplant?
yeah. So my main responsibility, the most simplified way that I explain it is, I just keep patients moving while they're in the hospital going through treatment. Bone marrow transplant is, you know, supposed to be a curative effort for patients that have hematological malignancies. So primarily our leukemia and lymphoma patients are going to be the bulk of the patients that end up going through the transplant process. But we'll also see patients with other diseases of the bone marrow, myelodysplastic syndrome, multiple myeloma, myelofibrosis. Those are the patients that are end up going through, kind of that initial workup when they're newly diagnosed, go through induction chemo and consolidation. And then if they can get those patients into a position where they're in remission, they have a good match for transplant, they'll end up progressing to bone marrow transplant to hopefully kind of cure their hematological malignancy.
So is it just patients with cancer on your floor, or it sounded like you were naming a few other like hematological conditions as well?
Yeah, we do have a handful of patients that are going through kind of clinical trials for like autologous stem cell transplants for different autoimmune conditions as well. So we are part of the Beat MS trial, where we're doing autologous transplants for patients with multiple sclerosis. And then there's a couple other autoimmune conditions that we've been treating recently with more immunotherapy type treatments. So patients with lupus. We've done a couple of clinical trials for like different soft tissue sarcomas, things like that, using kind of modified T cells as part of our immunotherapy program.
Mhm.
So yeah, all cancer patients, or autoimmune patients, but the primary floors that I work on are transplant units.
So what leads somebody who's going through cancer to the BMT treatment or, the stem cell transplant treatment?
Yeah, there's a lot that goes into it workup wise. I know we have a question later on about kind of the multidisciplinary team, but it really takes a village kind of getting patients to the transplant process and then getting them through it. So again, it's like I said, it's going to be our patients that have hematological malignancies are going to be the primary group of patients that are going through bone marrow transplant. And so the kind of workup process for it, they'll meet with their doctor. Again, it's our patients that are able to kind of get to that position where they're in remission status, just genetics and things like that. Things are working out that they are a good candidate for whatever treatment protocol they have for their specific disease. So again, it's going to be a lot of leukemia, lymphoma patients that are going through this process. They get a full workup to make sure that just from a physical standpoint, they can endure the transplant process. So a lot of these patients, the chemo that they get as part of the prep regimen for their bone marrow transplant is going to be the most intense chemo that they go through. So they do an echo, they do a pulmonary function test, they take a look at their liver and their kidneys, just make sure that everything is functioning optimally. And then again, it's about finding a suitable donor for patients. So we have the NMDP, the National Marrow Donor Pool. And then also the docs will look at family to see if they have a match within their family. So we're looking for the best possible genetic match that we can, so that when that new immune system starts to repopulate, we don't have as many of the post-transplant side effects.
So that kind of brings me to my next question. What role do you see that rehab or that rehab plays while they're going through the bone marrow transplant or stem cell transplant?
Yeah. So a typical patient, so say we have a patient with AML, so acute myeloid leukemia, they're most likely going to be admitted to the hospital 5 to 7 days before their transplant date. So they'll come in and do their conditioning chemo prior to their transplant inpatient. And then they'll go through the transplant process. Is just like kind of any cell infusion. I know we make a big deal about it, but it's usually over in about 30 to 60 minutes. It's just like hanging a bag of platelets or a bag of blood. And then they go through this period of neutropenia post-transplant until they engraft or their white count starts to repopulate. So kind of our role differs based on where they are in the process. So like I mentioned, these patients are coming in remission. So most of them are actually doing pretty well, probably the best that they felt in a while when they come into the hospital. So we do a lot of education on the front end, making sure that we're keeping these people active, keeping them moving while they're in the hospital, especially initially while their counts are still up, they're feeling good, just trying to kind of optimize them for, enduring the post-transplant part of it. Um, we do, like I said, we do a lot of education on kind of safe mobility depending on how their counts are doing. Do a lot of education on energy conservation and pacing. We give them some guidelines on how active we want them to be during the day when they're in the hospital. Education on what exercises are safe depending on how their platelet counts are doing. Because the goal of the conditioning chemo is right to kind of bottom out their counts so that their bone marrow is ready to receive this new infusion of stem cells. And then kind of the post-transplant side of things is where things get really challenging for patients. Typically the first 7 to 10 days post-transplant is the really kind of hard part where the patient's counts bottoming out coincide with their post-chemo side effects catching up with them. So it's a lot of fatigue, it's a lot of GI symptoms. So that's really where I think we play the biggest role is when patients are feeling their worst. That's when we're in there keeping them moving, getting them out of bed, giving them things to do to stay active. They're really just kind of, meeting them where they're at and figuring out how to keep them motivated to get through until their counts start coming back up.
What kind of educational resources do you give these patients? Like what mediums do you use in your hospital?
Yeah, so we have a patient education packet that we give all of our patients that's also available to them through like our EMR. So they have access to it. So everything's written out for them. We have exercise handouts that we provide to patients. And then connecting them with other resources as well. BMT InfoNet is a great resource that we use for patients. I've recently been trying to filter as many patients as I can to other kind of more social support networks, like Cancer Buddy, Cactus Cancer Society, Elephants and Tea, just kind of giving them other resources that they can take advantage of while they're in the hospital to kind of find that support network to help kind of get through the process.
And at your hospital, what does the setup look like as far as how patients are exercising? Like, do you have a gym that patients can go to, or do they mostly exercise by themselves in their room?
Yeah, so unfortunately, no gym. Our BMT units are kind of spread out over 3 units in a single tower of our hospital. So um, We have stationary bikes on our units. We have two of them in the hallway on each unit, so patients have access to those. And then most of our treatments happen in the patient rooms. So lots of therabands, lots of teaching them how to like take advantage of all the bed rails on their bed to be able to set up different exercises. So I'll usually spend, a whole half-hour session just teaching them, how to manipulate their room to make sure that they're able to do the exercises they want. I know it's always pretty surprising to patients how good of how good of a workout they can get in a hospital room. Not too long ago, I had a Division I college football player that was going through an autologous stem cell transplant for Hodgkin's lymphoma, and big guy, defensive lineman, 6'5", 300 pounds, and didn't miss a beat. He was exercising every day, gave him lots of things to do. He had the whole rainbow of TheraBands set up in his room. So um, and he was surprised at how much he was able to do. So if I can keep a D1 athlete moving while they're going through this process, I think I can keep anyone going through it.
So it sounds like you can be pretty creative, using the resources that the patient has in their room, maintaining their
Yeah,
precautions, not needing too
yeah.
much external equipment for that.
Yeah, I'm always interested to hear about other hospitals that utilize having a gym on the unit for their BMT patients. The big hesitancy with our program has always just been infection control. Right, we're talking about patients that we're wiping out their entire immune system. They're going to go through 7 to 10 days where they don't have a detectable white count when they do their lab draws. So um, really important to, maintain good hand hygiene, keeping equipment wiped down and clean. So, um, like I said, I'm always kind of surprised when I hear that, there's a lot of shared equipment and things like that on these units, but we know what we're doing.
Yeah, my hospital, I haven't been up there treating patients, but my hospital has one. And I know that when patients go, they're always accompanied by, I don't know if it's a care partner or a nurse. I doubt it's nursing staff. I bet it's other staff. And I think they like review the labs to make sure the patient is eligible to go. So maybe at like a certain time during their stay that they're not eligible to go if they're so low.
Yeah. Yeah, we try to keep, so we consider patients neutropenic when their white count drops below zero point 0.5. So that's typically when, we're going to be really cautious about them being, out and about around other patients and, people milling around in the hallways of the hospital. And, uh, we look out for platelet counts less than 20,000 with any kind of resistive exercise, things like that. So I've had patients in the past that, you know, don't want to adhere to the precautions, so end up taking their therabands away from them. So yeah, I think it's a lot of, a lot of what we do is just patient education, really making sure that they understand why we're doing what we're doing, how everything that they're doing on the front end is going to make the recovery process a little bit easier on them. So
So what type of outcome measures do you use for these patients when you're initially assessing them?
yeah, so the one of the primary outcome measures that we use is the ECOG performance status. So if you haven't heard of that one yet, it's a 0 to 4 scale. Basically, like 0 is like no limitations, pre-diagnosis activity level, and then just kind of gradually more assistance as you go down the list. A lot of our patients, like I said, are coming in remission, so they're probably going to be like a 1 or a 2 on that ECOG performance status. And the ECOG scale kind of lines up with the Karnofsky performance status, which is a scale that our doctors use. That's a 100 to 0 in increments of 10, that looks at kind of patient mortality and their ability to tolerate the treatment. So everything kind of lines up between kind of where we see the patients are at and their performance status from a medical standpoint. And then other more PT related outcome measures that we use in the hospital, we use the AMPAC 6-clicks as kind of just our general mobility outcome measure. And then we'll use dynamic gait index. We'll use a 6-minute walk test, 5 times sit to stand. grip strength assessment just to kind of get a better picture of where our patients are at functionally when they're going through this process.
And is that the same for patients that are going through a bone marrow transplant and stem cell transplant?
Bone marrow transplant, stem cell transplant, kind of used interchangeably. Um, yeah, and then we'll use kind of the same outcome measures for our patients that are there going through CAR T cell therapy and other immunotherapies as well.
That's my next question. I feel like CAR T is such a hot topic right now.
Yeah, especially with on the inpatient side. I know we were talking just before we logged everyone else on about we're starting to switch a lot of our bone marrow protocols to fully outpatient. And so our units right now, we're probably 60-40 inpatient CAR Ts over allogeneic and autologous stem cell transplant patients. And yeah, things are definitely heading that direction.
So what is the difference that you're seeing in the inpatient version versus the outpatient version of this?
Um, with our bone marrow transplant patients, the patients that are going through the outpatient protocols are typically going to be our more robust, healthier patients that are going through that process. So we're seeing a lot of the sicker and kind of older, maybe like borderline qualified for bone marrow transplant patients on the inpatient side. So we're seeing a lot of longer length of stay, just tougher recoveries for those patients that are, on the frailer side when they're going through that process.
So it's more so a question of where they're starting out,
Yeah.
and that's how they're determining is eligible for the outpatient.
Yeah, and it's protocol specific as well. So I think right now we have if 4 or 5 of the protocols that we use are solely outpatient protocols, unless the patient has a side effect or something that leads them to being admitted to the hospital. And so, yeah, those are going to be kind of our younger, more fit patients, less comorbidities, able to tolerate the conditioning chemo without a bunch of side effects. Those are going to be the patients that are going through those outpatient protocols.
And what does this look like for the outpatient protocol people at home?
That's a great question. We don't see a lot of these patients. So they are getting our like educational handouts and things like that through the EMR. But as far as our institution goes, we don't have a PT touch point with those patients when they're going through this process. So they're kind of getting that information and education secondhand through their nurse coordinators and things like that. So um, yeah, we're usually not seeing those patients unless they're admitted for post-transplant side effects.
So that's interesting that like you're seeing the ones that are coming in for the inpatient, but not really getting an idea of what's going on with the outpatient ones. So I
Yeah,
guess we'll see how that evolves.
yep. So trying to fix that. So I know that's we were talking about that earlier too. It's weird that such a large institution doesn't have a rehab presence in our outpatient cancer center. But we hopefully have a couple of projects going on right now that should be hopefully solving that problem.
Mhm. I know for my hospital, when they're, getting ready to start doing the outpatient ones, I think they're going to have, like, when they have the patients come in to the hospital or to the outpatient facility, um, they're also going to have the PT go up and like see them maybe do a treatment or so with them. So that'll be interesting to see how that gets integrated.
Yeah, so I'm actually our team lead on a pilot project that we're doing with our CAR T patients, where going over to the cancer center and doing functional pre-assessment with them, like when around the time that they're doing their apheresis for their CAR T, and then getting them set up on a prehab program. So that's a 3 to 4 week program before they're admitted. So yeah, hoping that we can expand that to our bone marrow transplant patients eventually.
Mhm. And I am seeing these questions in the chat. We'll go through those at the end as well. Um, Going back to the more inpatient side, what are the yellow and red flags that you see with these patients? I know you were talking about lab values before.
Yeah, so a lot of the larger cancer institutions, looking at lab values, we're going to transfuse. If their hemoglobin drops below 7, they're going to get transfused. If their platelets drop below 10, they're usually going to get transfused. So just being cautious of, especially like fall prevention, things like that in the hospital. We're looking at patients who have, you know, less than 10% of what a healthy person's low end platelet should be. So, being very cautious that they're not doing things that they're not supposed to be doing. Like I said, no resistive exercise when their platelets start dropping. Making sure that they're not bumping into things, that they're wearing appropriate footwear so they're not, kicking the wheels on their IV pole when they're out walking around. Anytime that a patient's at risk for, any kind of skin breakdown, that's just another site of infection that's possible when their white counts bottomed out. Um, and then other things like just being aware of, what chemotherapy drugs they're getting as part of their pre-transplant conditioning. That if patients are getting hypotensive, if they're having fevers, things like that, that we're communicating with our nursing staff and making sure that we're keeping patients safe, not kind of trying to push them along to do things that they're not, that their body's not ready for.
And going off of that, I guess during and then after, what type of complications do you see with these patients?
All kinds of stuff. So we get kind of the whole gamut of, regular chemotherapy side effects. So we're going to see a lot of, anemia, low platelet counts, fatigue, mucositis, the ulcerations in the mouth and the GI tract. And then we get the special set of side effects with our allogeneic transplant patients. So those are our patients that are getting donor stem cell transplant, that have the risk for developing graft versus host disease, which can affect different organ systems. So yeah, kind of side effects are all over the board. Pretty much anything that you'll see with patients that are going through any kind of chemo. We have a lot of patients that are going through and getting drugs like etoposide or VP16, where we're seeing blistering on their hands and their feet. Um, we're seeing a lot of patients that are getting like Cytoxan as part of their pre or post transplant protocol that are hypotensive for 24 to 48 hours post chemo infusion. So um, yeah, all kinds of stuff.
And I know we touched on this before, but can you touch on again how interdisciplinary care looks for this population?
Yeah, so our patients are followed by a whole team of people. We have, our attending physician and then their APP group, their social worker, case manager, dietitian, pharmacist. Um, our team, we do daily rounds that our rehab, the multidisciplinary team does daily discharge rounds where they talk about all the patients that are on the floor, um, and then, so the nurses usually run those rounds, and then our attending physicians are there to kind of discuss where the patients are at in the process, and case management and social work's there to help make sure that patients that are getting close to discharge have everything that they need set up. Our patients are required to stay within a certain radius of the hospital when they discharge. So our social workers help arrange housing for patients and make sure they have access to all the things that they need. And then our rehab team, we go to multidisciplinary rounds 3 times a week. So kind of every other day, where they're letting them know, you know, patients that are getting close to discharge, if there's any barriers to them leaving the hospital. We talk about our long stay patients and things like that, what we're working on in rehab and kind of how close we think they are to being able to discharge. So yeah, it takes a village getting these patients through this process.
Sounds like it from start to finish, right?
Yep.
So I know we were talking a little bit about this before, but what can you tell us about post BMT and how PT may look like, or what these patients need following the BMT?
Yeah. So kind of the post-transplant phase, like I said, kind of the first 7 to 10 days post-transplant. It's just kind of getting them through that hard part until their counts start coming back up and they start feeling like a human being again. And then, once we start seeing that white count slowly start creeping back up, that's when, we kind of really try to get them ready to get out of the hospital. So really pushing the mobility side of things. We're doing DME assessments, we're doing caregiver training, stair training, whatever those patients need to be able to safely discharge from the hospital. And then again, it's looping in case management and social work, making sure that patients have caregivers set up, that we're getting equipment ordered for patients that need it. It's one of the really like weird things about our job, because as PTs, right, our whole thing is making sure that we're keeping patients moving and of optimizing them from a physical standpoint. I think we're the only service line in the hospital where patients leave in worse shape than they came in. So it's really just making sure that patients are moving well enough that they can safely go home with the support of their caregiver. We're addressing whether or not we think that patients are going to be eligible for home health services, things like that. Our physicians are really hesitant about sending patients to like skilled nursing facilities or outpatient PT clinics just because they're so immunocompromised. So usually we, don't clear them to do outpatient PT until after day plus 100 post-transplant. It's kind of the golden number with our allogeneic transplants is if we can get them to day plus 100 without any major side effects, they tend to do pretty well. So um, it's a lot of coordination, just making sure that everyone's on the same page to get these patients out safely and make sure they don't bounce back.
I know that right now, like in oncology, we have specifically prehab is like this big phenomenon. Everyone's trying to do prehab, prepare these patients for the treatments that we know that they're going through and for the side effects that they're going to have. What do you think the role is of prehab for these patients?
I think it's really important. We're trying to optimize these patients functionally as much as we can before they go through these really hard treatments. The hard part about it is just the timing, right? Like we don't have huge windows of time between when a patient is, newly diagnosed and when they're going to go through bone marrow transplant. Some of our patients, they'll get fast tracked when they're in the hospital and they'll go from induction and consolidation. They may have, a little holiday from the hospital where they're out for a couple of weeks, but if they're in a solid remission and they have a 10 out of 10 match donor ready to go, we might fast track them to come back in for their bone marrow transplant. So I think prehab is important when we have the time to do it. I think we have a little bit more time with our CAR T patients because we know that it takes, 21 to 28 days to manufacture the cells that they're going to reinfuse. So we have a 3 to 4 week window where we can, we're probably not going to make any major improvements in patients' fitness level prior to their admission, but it starts building those healthy habits, walking daily, getting them into a strengthening program where they can continue to carry those things over when they're admitted in the hospital. But we get patients that are really sedentary and then they get into the hospital and they decondition really quickly. So I think the prehab side of things, I think the more exercise and activity we could get patients doing, that's great. But kind of doing the education up front and getting, kind of that groundwork laid that, these are going to be the expectations that we have for you mobility wise when you're in the hospital. Kind of keeps patients from getting really deconditioned, spending most of their day in bed. So I think that's where kind of the biggest impact that we can make on the prehab side is.
Mhm. Yeah, that makes sense. It might not be a big, episode of PT. It might just be that one visit just to at least let them know what what's gonna go on and how they can best prepare themselves. That makes a lot of sense.
Yeah.
What does a day in the life look like for you?
Yeah. So for me, getting to the hospital, I look at my patient list for the day and start chart reviewing. Typically, I'll see anywhere between 7 and 9 patients a day in an 8-hour day in the hospital. So I'm prioritizing patients, new evals and upcoming discharges are going to be the priority patients on my list. So looking at kind of where they are in the transplant process. So our patients that are still pre-transplant are getting that, kind of new eval and education session. And then, like I said, our patients that are getting close to going home, we're doing discharge education with them. We're ramping up their mobility, getting them ready to get out of the hospital. Um, so yeah, my morning chart review, looking at, patients' lab counts, looking at whatever tests procedures they might have going on that day, looking at nursing notes from the night before to see how they were doing the second half of the day prior. So um, yeah, just trying to figuring out my daily list, who's going to be appropriate to see in the morning, who I'm going to be bumping to later in the day. Patients that are, like I said, more priority patients that I don't want to miss. Especially those patients that are in for new evals. They're coming in and starting their conditioning chemo before their transplant. So, communicating with nursing staff, working around their chemo schedule so that we're seeing those patients when they're, physically and at a good point to try to work with us. And, like you said, having side effects from their chemo or, getting a bunch of Benadryl and stuff like that before they get their chemo. So, able to work with us.
So, how do you deal with deferrals? It sounds like you obviously have plenty of patients to see with the new evals and patients getting ready for discharge, but how do you deal with the deferrals based on people that just don't feel like exercising, or patients that you are deferring?
If there's like a medical reason that I'm deferring that patient, I'm scheduling them for a day or two down the road to, kind of let things even out before I try to see them again. Patients that are deferring because they're fatigued or nauseous or didn't sleep well the night before, those are patients that I'm going to try to find, a plan B or a plan C to try to get them to work with me. Um, and I think that's one of the hard things about, kind of inpatient hemonc is that, when patients are going through chemo, when they're going through radiation or stem cell transplant, it's really hard on their body. So I think that's where, getting them involved with PT early on in the process and, when they're feeling good, that's when we kind of build that rapport and kind of set that groundwork that, post transplant, you're not going to be feeling great, but I'm still going to be coming by to bug you and get you to do stuff. So, kind of giving them that out, that, kind of give them an idea of what you want to do that day, let them have some say in it, have kind of a lower level option available. We have like the little stationary pedalers that we can set up in patients' rooms. So if I have a patient that, is just having, GI issues post transplant, whether that's, frequency or urgency of bowel movements or, nausea and vomiting, and it's just hard for them to try to venture outside of their room. Those are patients that, there's lots of stuff that we can work on in their room, right? We can do balance exercises at bedside. We can get them on the stationary pedaler. We give them TheraBand exercises if their platelets are still up. So I think it's about making sure that you're kind of giving patients options so that they don't feel like, oh, if I can't walk today, it's going to be, I'm not going to be doing anything. So
So it sounds like there's a lot of tiers for these patients, like, let's start here, or if you're feeling more up to it, we can go there and we can go middle of the road.
yeah. The last thing that I want to do is kind of torch all of that rapport that I built with a patient because I go and push them to try to do something that they're not ready for, right? So, um, you know, it's hard enough being in the hospital for weeks at a time. So, giving them that choice, giving them a little bit of autonomy over their rehab sessions is, like I said, it's a great way to build rapport. It's a great way to get buy-in, get them to trust you that you're not going to be have them doing anything unsafe. I think that's one of the things we get a lot from patients is, I'm so fatigued. You're going to push me to, go walk or go ride the bike, and I'm just going to be more tired. I'm not going to be able to do anything the next day. But, doing that education that, this isn't the kind of fatigue that gets better with rest, right? Your body needs to learn how to adapt to where you are right now and be able to manage these side effects. So those are things that we kind of help patients get through.
So can you give us a little bit of a case study on a patient that you saw like physical therapy intervention made a big difference for them, or maybe like a difficult patient that came around, anything kind of interesting that you want to highlight?
I think some of my favorite patients over the years have been like our long stay graft versus host disease patients. So um, I had a patient pretty early on in my career that like initial transplant admission, she soared through, did great, like no major side effects. Was doing really well at home, and then like 6 months post transplant, she's back in the hospital. She has grade 4, stage 4 GVH of her skin. So almost like an ICU level burn patient. She's going through, dressing changes that are taking multiple hours a day, not moving a whole lot. Um, on the other comorbidity, she was on the obese side. So mobility, she was independent, but she wasn't doing a lot outside of the hospital either. Just kind of mostly household mobility ADLs. So we did one of the things that we do for patients that have graft versus host disease. The first line of treatment for them is blasting them with high dose corticosteroids. So prednisone, solumedrol, and so these patients end up with really bad steroid myopathy, where they get weaker and weaker as they continue on these long courses of steroids to help try to keep their graft versus host disease under control. So uh, we basically had this lady that, we taught how to walk again, that went from, just kind of getting really debilitated by being stuck in bed, going through these dressing changes and being on a ton of steroids. And, we rehabbed her in the hospital for 5.5 months, where we were seeing her between 3 and 5 days a week, depending on kind of where she was at. So I think we initially it was getting her to be able to sit up at the side of the bed and hold herself up, to getting her up in a standing frame, to up with the Eva walker, this platform walker, to be able to start balance exercises and taking steps. And then she ended up eventually discharging from the hospital, and walking out of the hospital and going home with her daughter. So um, I think those are always my kind of go-tos. My favorite stories to tell is, we have these patients that, because they are going through different treatments for their graft versus host disease, we typically won't discharge them to another facility because the treatments that they're getting are usually daily. So whether they're on steroids and they're being monitored, whether we have patients that are going through like photopheresis and things like that. Um, to manage their graft versus host disease, they need to be in the hospital. So we essentially become kind of their long-term rehab team. Those are always the ones that are really, really satisfying when they start to turn a corner and we're able to get them moving more and get them into a position where, if they're medically able to, they're able to discharge from the hospital.
That's really interesting. I never kind of thought about the cross section between acute care, like hospital, and then kind of morphing into more of like a rehab style treatment for these patients.
Yeah. yeah, we get to a point where because of their medical complexity, right, they don't have a lot of options as far as being able to discharge to another facility. So they stay with us and we get them through it.
I know we talked about before the evolution of these outpatient transplants. Is there anything else that you see with like the future of the BMT rehab that you see to be interesting or a direction that it's going in?
I think one of the really cool things is that we're starting to see kind of crossover treatments where we're starting to combine elements of a bone marrow transplant with more of our like CAR T immunotherapy type things. So like we have a protocol right now for patients with B cell ALL. So these are kind of younger patients. These are late teens, early 20s, where they're basically getting a donor CAR T cell infusion on top of their regular bone marrow transplant. So they come in, they do their condition. Well, their donor goes through the apheresis process twice, once for the CAR T and then once for the stem cell transplant. So they do the T cell apheresis, they do the stem cell apheresis. And then patient comes in and they go through the regular conditioning protocol. And then on day zero, um, they will get their donor T regulatory cells. And then on the second day post-transplant, they'll get an infusion of T con cells. So now we have these T regulatory cells that basically tell all of the T cells what to do and where to go. And then we have this second infusion of T con cells. So now we have this like proliferation of T cells into their bloodstream. And then on day +4 post-transplant, then they get this infusion of donor CAR T cells that are now have this antigen where they're going out and looking specifically for the cancer cells. So it's really, the more targeted we can make these therapies, the better they're going to be. We're going to see less of the systemic side effects, the more targeted we can make therapies. So I think that's really the direction that we're heading is where, everything is going to be as modified to a specific patient as it can be. We're seeing now CAR T cell therapies where, they're taking a sample of the patient's own cancer cells and like picking what surface antigen they want to express on the CAR T cell. And so, it seems like science fiction at sometimes, but um, really the whole point of it is to make the therapy as targeted as possible. So we're seeing that with we're doing a trial right now with metastatic melanoma patients where we're doing it's called tumor infiltrating lymphocyte therapy. And so they're actually going into the site of their melanoma and taking out T cells that are expressing this receptor that knows how to go and find other melanoma cells. And then we're expanding them in a lab and then reinfusing them and letting them go to work. So um, it's kind of crazy to see how far we've come in a really short amount of time as far as T cell modification and immunotherapy has gone.
Wow. I mean, I think that makes every person interested in oncology just a little bit nerdy for loving all these
Right.
treatments. It's really interesting. Thanks for sharing.
Yeah.
Um, One more question before I head to the chat because I love that everybody's been asking questions in the chat. What advice do you have for anybody interested in starting to work in hematology, oncology, either coming out of school or somebody that's, been an experienced clinician?
I think my biggest piece of advice would be if you're able to get some experience or get a job at an academic institution. I think those are the places that are going to be doing more of the like clinical trials and cutting edge treatment. And so I think that's been really fun to be a part of. We were one of the first institutions to start the like Zuma 1 trials when we were doing Yescarta CAR T cell infusions. And so we were one of the first hospitals in the country that were treating these patients. This was back when, 2016, 2017, when, you go and you look up research and there's nothing out there about treating these patients because these treatments are brand new. And so I think that's been a lot of fun. I would say stick with, if you want to see a wider variety of patients, a wider variety of treatments, be involved with clinical trials and things like that. Larger cancer institutions and academic centers are going to be where you want to try to get your foot in the door.
Right, especially for something as specific as this. I agree.
Yeah, BMT and CAR T, I always, tell patients or tell people that, even within oncology PT practice, like BMT is a niche within a niche. It's, such a small number of PTs that are primarily treating this patient population.
All right, now I'm heading to the chat. Um, so I think we kind of addressed this before. How can we prep a patient going to a larger cancer center for BMT to help them before the BMT? So I guess this is like seeing patients beforehand, that are then going to be going elsewhere. So what advice would you give to a therapist going through this?
Yeah, like I said earlier, you want to make sure that those patients are staying as active as they can, leading up to that BMT process. So like I said, patients that are going to the transplant process are going to be patients that are, in remission, they're feeling good, trying to get them to really take advantage of their good days and try to push and really get themselves ready for, kind of the grueling process that it is being in the hospital for a month at a time. So yeah, just, find exercises, activities that are meaningful to that patient, that they're going to want to continue to do. Get them ready for being in the hospital for, weeks to months at a time is not easy for patients. So getting them in as good of shape as they can is going to help. Like I said, it's going to help them bounce back on the other side a little bit easier.
And then we have another question here about establishing plan of care for stem cell transplant patients. Does that change based on their post-transplant course?
Absolutely. So a lot of these patients are going to come in, they're going to be independent mobility wise. A colleague and I just presented a poster at CSM last year, about a pilot project that we ran, where basically any patient that is admitted for new BMT, that's screened as independent at eval, we kind of put them on a separate list within our EMR, and like remote monitor them through our nursing staff. And so, it's because there's no real point in patients that continue to maintain their independence and are adhering to all of the activity guidelines and precautions that you give them. Those aren't the patients where we want to be spending the majority of our time. As long as they're doing well, keeping an eye on them, making sure that they're doing what they need to do, but being able to utilize our resources for the more complex patients, the patients with higher rehab needs. So we have this list of independent patients, that we basically, like I said, monitored through nursing staff, checked in twice a week and saw how they were doing. Um, and then we would be able to pull those patients off of that list if they started having any functional side effects. Not being able to get out of their room, if we needed to pull them to start doing like caregiver training or stair training, anything like that prior to their discharge. But those are patients that we tried to kind of keep on that independent list from the time that they were eval until they discharged from the hospital. Um, you know, when our BMT program was on the smaller side, we tried to follow every patient that came in from eval through discharge. And so we would check in on them, once or twice a week to see how they were doing. We can always adjust that frequency up or down depending on, side effects that they were having, things like that. But the PTs that came before me in our BMT program, they really laid the groundwork for making sure that every patient that was coming in for a bone marrow transplant at least got a PT evaluation as part of their automatic order set. So we were putting eyes and hands on every patient that came in for transplant, giving them that education and making sure that we were doing everything we could to set them up for success going through that process.
The next question I have here, I know we touched on this earlier, but like, how would you explain the importance of exercising pre, during, and after transplant to a patient at a pre-transplant evaluation?
Yeah, I think um, kind of giving them an idea of what the transplant process is like, right? That they're going to be in remission coming into the process. So trying to maximize and move as much as they can early on when they're feeling well. And then kind of giving them that warning that, that first week post-transplant is going to be, probably one of the hardest weeks of their life. So making sure that, we're giving them little things that they can do to stay active. Making sure that they're sitting up in the chair for part of the day, making sure that they're trying to get up and take a shower if it's safe for them. Kind of prioritize kind of the everyday activities, their ADLs, things like that, that are getting them up out of bed. I'll tell patients that, aren't getting out and walking around in the hallway because, they're having, frequent diarrhea because of their post-transplant, GI upset, that every time that they're getting out of bed and making it to the bathroom, right, that's more time that they're up, that they're moving around. It's not the prettiest thing in the world, but it's keeping them active, keeping them on their feet. Um, and then, as they kind of get through that initial post-transplant phase, then we start ramping activity back up, getting them ready to go home, and then getting them into survivorship and getting them back to, being able to do the things that they enjoy doing. Um, and I'll always preface, when patients are getting ready to leave the hospital, we have some guidelines and things like that on activities that we want them to avoid, just because of, potential risks with low platelet counts, infection risks, things like that. And so, telling patients that, these are things that you're going to have to put on pause for a little bit, that you'll be able to get back to doing eventually, but the risk of some of those activities and them landing back in the hospital is not worth it.
So it seems like the next question I have is about like missed visits, and we talked about that a little bit before. Do you have any difficulty meeting your productivity standards with these patients?
Depends on the day. But I think, our rehab leadership is, understanding of, the transplant process. All of our patients that are in the hospital going through chemo, radiation, things like that. We know that, they're going to have days that, it's just not a good day for PT. We know that there's going to be days that, we miss patients because they're off the unit half the day for radiation or, other treatments that they're getting. So I I am a strong proponent about pushing back against productivity standards because, you know, the number of units that we're billing or the number of patients that we're seeing in a day is not the most important metric that we should be looking at when we're taking care of people.
Agreed. Amen to that. Another here about educational resources that you would recommend for people that are looking to get more information about this, about like the medical management of these patients.
Yeah, so BMT InfoNet is a great place to start. I think it has a lot of great information that is written in a way that patients can understand it. So I think we can pull a lot out of it, as rehab providers, you know, higher level of education. I think we're going to get a little bit more out of that. Leukemia Lymphoma Society has great resources for patients and rehab providers. Uh, if you want more resources about like the medications that patients are getting, so like the different chemos, chemocare.com is a great place to kind of see what side effects the patient's potentially going to have from the medications they're getting. The NCCN guideline handbooks for patients with leukemia and lymphoma are a great place to, get a little bit more understanding of the medical side of things. So lots of great resources out of there.
Thank you for that. Um, and the last question I have here is, are there any specific exercise guidelines that you want these patients to adhere to during their hospital? I know you're talking about whether you're going to defer or not defer, but the guidelines based on their blood counts, but is there any other exercise guidelines that you follow?
Yeah, so the very generic guidelines that we give our patients as part of kind of that educational packet that we give them at eval. We tell patients we want them out of bed for at least 6 hours a day. So any combination of sitting up for meals, taking a shower, going out for walks, doing exercises in their room, we want them out of the bed for at least 6 hours a day. And then the other thing that we tell them is we want them to do at least 30 minutes of aerobic exercise per day. So again, any combination of walking, stationary bike, pedaler, anything where they're getting that little bit of aerobic activity in. And then I'll always preface that too with, we know that there's going to be days that, it's really easy hitting that 30 minutes of aerobic activity. And there's going to be days where they're not going to get to that 30-minute mark. And so it all kind of evens out by the end. The biggest piece of education that I give patients when they're in the hospital, take advantage of the days that you're feeling good, try and push, do more. And then those days that they're feeling really beat up and run down from their treatments, prioritize the everyday things, sit up for breakfast, take a shower. If you have anything left in the tank, try and squeeze, a short bout of exercise or a short walk in. I tell them, this is not an easy process to go through. So, you want to make sure that patients are giving themselves some grace, but, being firm about the reason that we have these guidelines in place is to make sure that when you're ready to leave the hospital, we don't have any functional reasons to keep you inpatient and make sure that you're ready to go home.
Awesome. Thank you so much again, Adam. This has been really great and really thorough as you ran through what you do, and this is really awesome. And thank you for answering my questions, all the questions in the chat, and thank you so much, everybody, for doing resources in the chat and being very active with your questions. Really appreciate that. And we would love to see you all at some of our next webinars. We'll be putting them out on our Instagram and on the listserv, so stay tuned.
Yeah, thanks for having me. Um, if anyone wants to reach out, uh, I'll give you my email address. People can kind of reach out to me via email. So
Yeah, sounds great. Do you want to just put that in the chat right now?
yeah, I can do that. And then I'm always active answering BMT and CAR T questions on the oncology listserv too. So
Awesome. Well, thank you so much, everyone. This has been really great. And thank you, Chitra. Also, I'll have to see you. I'm in the outpatient, so I'll have to stop on the BMT floor to see you in UT Southwest soon. You can unmute yourself if you would like to. I see you have your hand raised.
No, I have been trying to reach Adam, and I'm so lucky to have found this webinar. I just sent him an email, I think, a couple of days back because I was
yeah,
caught up with something else, and then I find a chance to read his posting in the oncology listserv about BMT patients, because currently we are working on a project to reduce the number of screens and missed visits, and we just started talking about this 2 days back with leadership, and then I just saw Adam's talk today, and I was like, I need to get on this and talk to him. I found you.
I'll, I'll get back to you. I'll send you an email tomorrow.
Yeah, thank you so much. Thank you both. This was really wonderful. Thank you.
Yeah, no problem. Thank you.
Mhm.
Thanks for having me.
You're welcome. I'm just gonna stop this recording on the cloud. Okay.